thank you for your willingness to participate as a speaker in our ground rounds. As we always mention, we try to blend here in these ground rounds the different areas of infection prevention and control, antimicrobial stewardship, multi-drug resistant organisms, the areas of microbiology. But at the same time, if there is any other topic that the audience would like for us to address, we are open into the big field of hospital epidemiology and infectious diseases, and continue with our interest in the area of patient care and the challenge of patient safety. And Dr. Garrett is going to give us an overview of this so important topic at this moment. We want to thank Hudson because he's always, whenever there's an important hot topic, he's always have been reading the literature, have been doing some work, and he's always willing to give us an overview of the topic. We hope that at the end of the presentation, we have comments or questions to keep the discussion open. And Hudson, thank you very much. You can move forward, please.
Thanks very much, Dr. Ramirez and Dr. Carrico, for the invitation. Good to see so many familiar faces. And as Dave dropped in the reminder about boot camp upcoming, hope to see many of your smiling faces at the conference in person in Kentucky. It'll be so nice to see everybody after a period of time. When Ruth asked me to sort of put together this topic, it was really one that I think is pretty special, right? For a lot of different reasons, many of which Dr. Ramirez talked about, because patient safety is really the conduit for all of the different sciences that we practice, whether you're in infection prevention, whether you're in healthcare quality, risk management, infectious disease, it really doesn't matter, because everything that we do is really centered around impacting the patient and hopefully taking care of the patient in a better way each and every time we actually interact with them. So I really wanted to hit on sort of three basic things today. And I've tried to take this in more like a Letterman approach, if you will, almost like a top 10 list of sort of patient safety threats affecting healthcare. And this is really based on a lot of the data that's come from the ECRI Institute. If you're not familiar with ECRI, they do a really great job of looking at data, not only in the healthcare space, but also from places like insurance companies, manufacturers, the FDA, and really putting together a pretty robust list of threats that are going to impact healthcare. The second area I want to explore with us today is really looking at the breaches, right? Where are some of the areas that we're likely to have some of the breaches? How are those going to impact patients and frankly us too? And then lastly, how can we hardwire some of these best practices so that when we're looking at this in terms of high reliability systems and organizations, we're not causing preventable infections within our patients? And so if we think about healthcare, right, the US healthcare system has changed dramatically, even over the last 5 years, certainly the last 10 to 15. And part of it is good. And I think we would all agree that part of it is probably not so good. There's always a double-edged sword, right? As we put more emphasis on things and we start to measure certain different outcomes, we know that we're going to be looking for that. We're going to sort of, flip that rock over, look for that data, try to understand the problem. But that also means that we divert our attention away from other things that might be important, like some of those core practices for infection prevention. And so as our patients and the public demand more transparency, which we all agree we want, I certainly want that as a consumer of healthcare, there is a burden that then is placed on us when we're doing public reporting. We've got sort of the concept of preventability, right? Is everything that we do truly preventable? Are all of our interventions truly going to result in a zero healthcare associated infection environment? The answer is no, but that certainly should be our holistic goal. No patient comes in and says, I'd like to get that elective healthcare associated infection, right? They're not signing that as part of their informed consent process. What they're really doing is entrusting us to do everything in our power to prevent those preventable infections, but also engage them in the process. Then we add into that CMS incentives to try to reduce these preventable incidences, which is great because we know that healthcare is very much driven by profit as well as financial incentives. And so if we say, hey, we're not going to pay you if you do the wrong thing, but we are going to pay you if you do high quality care, right? That does drive things in the right direction, but we can only expend so many dollars. And then, of course, we've got this sort of concept of national expansion, especially with things like antimicrobial resistance. And so the complexities of healthcare have continued to evolve. Now, some of you are dialing in from skilled nursing facilities, some maybe from ASC, some from hospitals, some from public health. And it really doesn't matter where healthcare is delivered. I always tell this story that my little brother is a malpractice attorney. He works for Morgan and Morgan, which is the largest, personal injury firm in the United States. And we have some interesting conversations. And one of the things he's always sort of sunk into my head was, it doesn't matter where you deliver healthcare, Hudson. It's the fact that it's healthcare, right? The patient's expectation of safety and reliability and standard of care exist universally. So if I get, my blood drawn in a blood mobile at a Red Cross, type event, it doesn't matter. All right. It's the same expectation of safe care as if I'm in a hospital. And so we have to really look at the complexities of that. The other thing to overlay on top of this is that the devices that we use, the different products and solutions and technologies, all of those have also increased in complexity. And we've not necessarily kept up from that perspective, which is really challenging. So technology is a good and a bad thing. I think we would all agree to that. Some of us love technology, some of us hate it. Last night, I was trying to make a change in a webinar system. And for the life of me, I've done this thousands of times. It worked 100% of the time until last night. And I thought I was losing my mind. And it turned out that there was a system outage, right? And so it was a huge inconvenience, but it also reminded me that technology can fail. Now, was the consequence big? No, right? This was a webinar. It was not something that was life and death. It could wait till tomorrow, or today, should I say, and it could be fixed. But a lot of the technology that we use in healthcare does have serious consequences when it's not properly designed. We don't properly maintain it. We don't properly actually reprocess it, for example. And so there's always these human factors elements that we have to consider in the context of healthcare quality. And then you've got this sort of, element of healthcare making us sick. And this is challenging to combat, right? Especially when patients start to ask, well, does your hospital have this? Or have you ever seen this? Do you ever have infections with your patients? I remember asking my ENT surgeon many years ago when I had sinus surgery, I said, what's your infection rate? And he spun his head around and he said, why are you asking me that? And I said, well, every patient should be asking you that. And he said, I don't have infections. And I said, you're clearly not the surgeon for me if you don't even know your infection rate, right? And it was that they didn't even track it. He was not even interested in it. And he said, well, I don't have infections. And I said, well, how would you know that? And that led into a conversation where we decided that we were not a good match for each other. Went to a different surgeon who was extremely proactive, very aggressive in his management of SSIs, and he could give me all the different things that he did. He gave me his procedural specific infection rates. He talked about what he would do perioperatively, what he would do sort of postoperatively, and what he expected me to do in the process. That was the surgeon for me, right? Because we had sort of this collaborative relationship to make sure that healthcare didn't make me sick. And so ECRI put out the 2022 top patient safety concerns. And, you'll see some of these are no surprise, like staffing and, how COVID has impacted us, looking at things like, non-ventilator healthcare associated pneumonia, human factors, and telemedicine, right? And what I've tried to do is take this a little bit more granular and break this down into some tangible things that I think we can all appreciate, but also really sort of put in our top 10 list. The first one, just like ECRI, is healthcare staffing, right? Without good, high quality staff that are well-resourced and empowered and well-rested, it's really impossible for us to deliver upon our promise to our patients successfully. I don't want just good care. I don't want just mediocre care. I want great care. I actually just went to the dentist this morning, and the reason I love my dentist is not only are they just great clinicians, but they also have great customer service. And so that is something that really stands out. And I will be a customer of theirs as long as they're there, as long as they don't change that attitude. And that's what we want to see more of, is how do we really have better customer service towards each other? How do leaders have better customer service towards their teams? So that regardless of what your role is in healthcare, we are taking better care of each other. I'm a big believer in a very, core concept: treat others with respect. It goes a long way, right? Regardless of all the different politics and everything that's happening in our world, if you treat people with respect, you can usually get respect back. And we can do so many things together as healthcare leaders and providers. We also know that a lot of clinical training was sort of knocked down into the back burner, right? Because, students were not getting access to real world patients. And so over the last 2 to 3 years, we saw a lot of folks that were graduating with many professional programs, including medical school, where they had a lot more simulated patients than they actually did real patients. And so this is something for us to worry about for sure. And then we've got the financial component, right? Where we know that the healthcare is not going to be able to financially absorb the cost of this. And so this is going to be a big challenge. I was reading an article last night, actually, from an ER physician that said he was leaving emergency medicine because he simply couldn't stand how patients were being treated and how leaders were not trying to, essentially address some of the almost PTSD impacts that COVID had following the pandemic. The second one that I picked was undependable supply chains, right? This is not just a healthcare topic, but this is when we go to the grocery store, when we go to Target, maybe when you order on Amazon. It really doesn't matter. We are seeing continuous gaps in product supplies. Now, luckily, we're doing pretty well with PPE, but 2 years ago, that was not the case. And we all saw the consequences of that. We saw the fear, we saw the dismay, we saw the mistrust that was taking place there. And if somebody were to ask me, have we truly legitimately learned our lesson related to supply chain in healthcare? I'm not sure I could honestly answer yes. Many of you may agree with that statement. Some of you may not, and that's fine too. Maybe your institution has done a better job of stocking up and thinking about pandemic preparedness. But as a country, we've still not really done a great job of that. And now CDC is, going through this massive reorganization. And I really hope that that's going to be a big piece of this, to really look at how do we arm healthcare facilities and specifically give better resources to our state and local public health departments to staff them back up and try to make sure that they've got the resources needed. The other component to this too is that a lot of our drugs are made overseas, right? And so certainly understand the cost component of that to take costs out of the healthcare delivery system, but that puts us at a lot of disadvantages when we need actual supply chain, especially with redundancy. Number 3 is new technologies. Now, anybody who knows me, and Ruth is probably going to laugh when I say this, I love technology. Dave knows this. I love technology. Dave's the same way. I remember when Ruth actually got her MacBook, it was almost like converting somebody over in time, because she had been a lifelong user of Windows. And now she has everything Mac. She has a MacBook, she has an iPad, she has an iPhone, right? And everything syncs to each other. But that was a challenge because some people are a little bit more resistant to new technologies. Others really are big embracers. But when we think about like electronic health records and some of the other programs that we use, NHSN, some of the other things that are routinely used in healthcare, specifically in infection prevention, there can be challenges with that. And with any new technology, there's always that risk of an unintended consequence. And so whether it's a new medication or new medical device, or maybe you're in a clinical trial, there's going to be inherent risk. Risk is not always bad. A lot of times we can mitigate that risk, but we still need to understand what the impacts could be, specifically as we look at different treatment and diagnostic modalities that might exist there. Number 4 is a touchy subject, right? And I know several of you personally on this call that are working in public health. And I want to start with a huge thank you, because public health has always been sort of the redheaded stepchild in many instances. It was sort of this group of people that were always there, but sometimes underappreciated, right? And then this pandemic hit and everybody said, where's public health? We need to get them here. And we can't do that, right? We can't sort of, take you off the shelf and put you back on the shelf. It doesn't work like that. Public health is there for a reason. It's integrated as part of our healthcare delivery system. And so I have immense respect for our public health professionals and the work that they do. Kentucky's fortunate that you have regional infection preventionists, right? Many states don't have that. So take advantage of these resources, but also recognize that there's limitations with every system that we have. And so using our public health laboratories more effectively, getting hopefully more resources from the feds in order to look at more syndromic surveillance is also good. but really getting meaningful data is going to provide us the best possible solution in terms of stopping outbreaks before they become pandemics and really understanding pandemics from a truly data transparent standpoint, right? Data is power, but good data, is really helpful. And a lot of times we put bad data in and we get bad data back out of the system that we're trying to do. Number 5 is one that Ruth and I frequently talk about. We've actually done some lectures together, and she was involved in the development of the core practices with infection prevention for the HICPAC committee with CDC. And I remember telling her when this was coming out, I said, this is probably the most influential work that you've ever worked on. Because it is really the core essence of, if we do these things right all the time routinely, we can really knock down the incidence, the severity, and the mortality and the morbidity that's associated with preventable healthcare associated infections, right? And so when we think about those core interventions, it's basic stuff like washing our hands, following aseptic technique, and not reusing needles and syringes, having good leadership support, disinfection of surfaces, right? Monitoring our practice to make sure that what we're doing is actually effective. These are not hard things, but a lot of times, again, we take our eye off the prize and we move on to something else. This is why I'm not personally a fan of having, May is hand hygiene month, or, something else is CAUTI prevention month, right? That is really an unnecessary focus at one particular time during the year, when in reality, we should be focusing on these things all throughout the year with every single patient. If I wash my hands, I reduce that risk of cross-contamination. If I don't contaminate that sterile item and handle it aseptically, I'm not going to introduce foreign pathogens into that patient or to that item. There's really simple things that we can do. And so the rationale behind this was CDC said, we've got a lot of things that are different guidelines that maybe somebody doesn't go look there. Maybe they're looking at the CLABSI guidelines or the CAUTI guidelines or the isolation. And we wanted to sort of combine this together to say, how do we get this into a single document that reminds healthcare practitioners, hey, these are the things that we should focus on every single interaction with patients, right? And so it was really a nice carve out so that we don't have to go to multiple different documents and read these lengthy documents, but rather go to a very simple guidance document that says, focus on these core elements, do these things routinely, and you will see huge dividends in the return on investment from an infection prevention standpoint. Number 6 is the wrong focus on regulation and accreditation. Again, this can be a little bit of a charged subject. Some of you may be Joint Commission inspected, some of you may be CMS, some of you may be DNV, some of you may be HHC. Doesn't really matter, right? All of them have some type of teeth that they can sort of sink into you, if you will. But if you were to ask the average nurse at a bedside, how do you feel about Joint Commission? I don't think in years I've heard anything positive. You probably would agree with that statement. If you mention the word Joint Commission, people literally get angry, they get frustrated, they get irritated, and they want nothing to do with that. And so we have to move away from this sort of focus of accreditation compliance to how do we make sure accreditation is a driving force to maintaining good best practices, advancing evidence-based practice, really looking at quality improvement, this patient safety science, because we don't want to get ready for the survey. We want to get ready to prevent harm, right? And that prevention of harm should be taking place every single day of every year. It's not just within our survey window. And we've got to sort of work on that, right? There's also OSHA. OSHA really failed us during the pandemic. They came out with this really long, robust standard about halfway into the pandemic. And we all sort of laughed and said, well, that was a little bit too late because we've already been doing these things for a period of time. And so timing is everything. And so if you're going to be a regulatory agency or an accreditation body, we need to do things that actually matter, not things that are just checking a box. And so I really think that the sort of fault there is with CMS. We need to make sure that CMS is focused on the right things and then holding these deemed regulatory and accreditation authorities accountable towards that. Number 7 is one that I'm pretty passionate about in the sense of future pandemic readiness, right? And it's really the lack of cross-training for healthcare professionals. Let me just give you a real-world example. So I've got many friends that live here in Atlanta that work in anesthesia. Many of them work in a pediatric hospital. So that's in Children's Healthcare of Atlanta. It was interesting to me that during a COVID-19 pandemic, their whole department was furloughed for actually several weeks. because there were no elective surgeries taking place. So they only did emergency surgeries. Now, I'm thinking to myself, well, how do we actually justify furloughing an anesthesia provider that is an expert in vascular access and an expert in airway management, when especially in the very beginning of the pandemic, we had a lot of patients that needed ventilatory support. And so it was unfathomable to me that healthcare leadership would say, let's not use those people in other capacities. Now, granted, we were not seeing pediatric hospitals at the beginning filled up, but that doesn't mean that those folks couldn't get emergency privileges and go across the street in other places, right? And so cross-training is huge. I sort of put together a list here of things like ventilator management, some basic critical care skills, right? Advanced vascular access management and sort of monitoring, and some really core elements of infectious diseases. We want to make sure that our intensivists, our nurse practitioners, our PAs, our pharmacists, everybody that's involved here is part of that. I'll tell you, there's also a really important group that a lot of hospitals already employ that they're probably not using to their fullest potential that can do a lot of these things, which is paramedics. Many hospitals are using paramedics in their emergency departments already, but they're not letting them practice to their full license level. And so these are folks that can intubate, they can place IO lines, they can do all kinds of skills that are quite advanced that even some providers are not able to do unless they're deemed competent for that. So we need to be very, very thoughtful in our approach to really creating more cross-training, giving people opportunities, and frankly, paying them for that too, so that they have some incentive in that game. And that really leads us to the sort of core context of competency. Just because you're well trained or you've had a lot of training or certifications does not mean that you're competent. Even if you have a certification, people always get upset by this. A professional certification, by definition, is a minimal level of competency based on a national job analysis. So if you are board certified in your specialty, that means that, let's say that Ruth and I are both board certified in a particular specialty, we have an equal level of competence based on a national job survey of our field, right? But it doesn't mean that we're experts. It means that we met that minimal competency. Now, as a supervisor or a leader, am I going to hire somebody that is certified over someone who is not every day of the week, right? Because it does give that person a leg up in terms of, hey, they demonstrated through a national exam that they were sort of able to master that knowledge, but also they're going to maintain that competency with continuing education. And so knowledge has to be put into practice. Practice has to be maintained. And so, retaking tests is not a really good measure of performance, but doing a lot of CE, especially CE that is performance-based and is competency-based. And we're seeing a lot more of this with some of the specialties. The neonatal nurse practitioner arena does this well, where they actually give you an individual performance assessment based on your practice in areas of strengths and weaknesses. And that's the CE that you do. And I think that's a fantastic idea because it individualizes the CE process for each clinician as they sort of renew their licensure and certifications. Now, one thing that we've got to do, though, is get away from this day-to-day stuff, that minutia. It's hard to do that, though. Right. We know that we have to get certain things done, and we recognize that. But part of this, too, is to say, what can we do that's going to be more of a strategic grab, a more of strategic impact? How can we actually get a bigger bang for our buck and really move that needle forward? And a lot of this is going to boil down to what level of leadership do you have in your organization? How engaged in the process are they? Are there things that will be helpful in sort of getting leadership engaged at the forefront? I saw something on Facebook this week, and it was a CEO of a very, very large health system, and I can't remember which one it was. It was in the Northeast. And the CEO, the CFO, the CMO, and the CNO, all 2 days a month, literally put on scrubs and go work in a different unit in their health system for the entire day. They work a full 12-hour shift. Right now, some of them are not clinical, and so they can't do clinical things, but they shadow, they help with patient care, whatever the clinical team needs. That is a pretty amazing way to recognize that leaders have to be in the forefront and to really show your staff that you are being strategic in your approach, that you do want to understand their sort of challenges, right? And for executives at that level to block 2 days every single month, 12 months a year, tells you that they are trying to be leaders from the very forefront. And a lot of this boils down to that human factors perspective, right? Can we reliably perform the task if we have the same level of training? Do we have the same type of oversight? We've seen this in a lot of system failures, even with the horrible situation with the nurse in Nashville, where, the system completely failed, right? Being able to override a system and then give a medication that was incorrect shouldn't have happened, but yet it did. And so who do you blame, right? Well, obviously, in the court of law, they blame the nurse. But in the reality of the patient safety component of this, it really was a system related issue that we have to address so that it doesn't harm another patient. Now, the complexity of our workflow, right, changes every single day. If you're in a clinical role, that's going to be different than if you're in a non-clinical role. And so we have to recognize that every single scenario may be slightly different from that component. And there's a lot of different sort of factors that are influencing this. It could be technology, it could be time management, it could be organizational, it could be political, right? You may have politics in your organization that are just really causing a lot of stalls where you can't get things done. Maybe you have leadership turnover is another one, or you've lost a lot of your team members. I know here in Atlanta, we've seen a pretty big exodus of some of our more experienced clinicians because either they retired early, maybe they were given early retirement options and they went ahead and left healthcare, or some of them are just doing traveling and they're no longer here in Atlanta. And so that has created sort of a big void where we have lost sort of that top echelon of really, really experienced clinicians because they moved on to other things. Number 8 is ineffective patient education. Right. One of my favorite examples is you come to the ER and they can't figure out what's going on. And then they figure out, oh my goodness, your blood sugar is almost 1,000. You're a new onset type 2 diabetic. And they give you this patient handout that's 62 pages long. And they say, go forth, go see your primary care doctor. Have a great day. Right. We see this happen all the time. We are great about giving patient education handouts. We are terrible about giving actual patient education. Right. And this particularly is seen in the ER. We see this also in some of the outpatient places as well. And so there is massive opportunity for improvement here. The more that we can do on focusing on chronic comorbidity care, the more we'll see reductions in a lot of our other care associated costs. A lot of disease is really tied back to systemic inflammation, right? If you look at CRPs as an example, C-reactive proteins, you'll see a lot of correlation back to certain types of diseases. And yet we don't necessarily manage these patients holistically. We don't really look at the full picture. And so this is why having a primary care provider is such an important element of that community healthcare model. And so we've got to really deal with that. We've also got to deal with where the patient comes from. Is this a patient that is super literate in healthcare, or is this a patient that's going to have some challenges? Do they have access to care? Do they have access to equipment? Telling an asthmatic to use a nebulizer, but they can't afford the nebulizer, that doesn't work. And so we can tell them what to do all day long, but it doesn't mean that it's going to actually become reality. And so we've got to really meet the patient where they are and really work with our primary care providers. Part of that, right, is to get the diagnosis correct and then make sure everything that's needed to take care of that patient can actually happen. We see a lot of misuse of emergency departments. And I would love it if we could figure out some type of triage way before the patient ever gets to the ED, where their triage should just say, okay, nope, you're not a candidate to come to the ED. We're going to send you to this urgent care. Now, some hospitals have figured this out and they sort of do a consolidated triage, and then they do have an on-site urgent care. That's a great model. Right. But even getting patients to and from their appointments can sometimes be difficult. We even saw this during COVID where, we didn't have enough Uber drivers and stuff like that, and people didn't have cars. And so we've got to really, really be considerate and thoughtful about that approach. Number 9 is what I call invisible healthcare leadership, right? They sit up in the ivory tower and you never see them. And they're sitting behind closed doors, and leaders have to lead from the front. Now, you don't have to be a servant leader, but I'm a big subscriber. That's the type of leader that I am. I fully believe in supporting people and watching them grow. I can tell you from personal experience that Ruth Carrico is the exact same way. There is not enough nice things that I could say about that woman and all the mentorship she's given me over the years of my career. She just inherently gives of herself, right? And so leaders lead from the front. They make themselves visible. They're not there for themselves. They're there for you. They're there to help you grow. And so the more that we can be in the forefront of healthcare, in front of the teams that need our support, and also be honest in our assessments and say, this is what worked. This is what didn't work. Tell me, guys, what you think we could do better, right? Ask the team that does the work for their input. because that's going to allow you to more effectively communicate. You're going to get better outcomes, and you're going to have more trust from that perspective. And if we think about that, it really also still puts the patient in the center. Now, we can't deliver patient care, though, without good teams. And so I think that that's been a fundamental change over the last 3 years, is that it's not just patient safety. It's not just patient-centered care. It's also, how do I make sure I have enough good resources clinically to deliver patient care? You know, so many hospitals right now, it's not that they don't have enough beds. They don't have enough staff beds. And that is just a huge challenge that, God forbid, we were to have another catastrophe like COVID, we could have some really big, big problems within healthcare. And so that really requires us to sort of look at this from a teamwork dynamic standpoint. And getting buy-in, right, from frontline staff is going to require a constant amount of visibility, a constant amount of follow-up to make sure that if you say you're going to do something, follow through with it, make sure it's visible, go back to the staff. Even if you can't do what they ask, say, here's what I tried to do, here's why we can't do that, here's what I think may work, would this work for you? Or ask them for more solutions. That is always a helpful thing from that perspective. There's also this concept that comes from some research that the Agency for Healthcare Research and Quality did, which they call the level 5 hierarchy, right? And at the very bottom is a highly capable individual. So maybe this is your best absolute rock star nurse. And then you've got somebody who is more of a contributing team member, and they start to work effectively on a team. So maybe that now is a nurse practitioner that is becoming part of a provider team, all the way up through that level 5 executive. Right? Ruth is somebody who is at that level 5 executive. She doesn't like to talk about it. I'll tell you that. She's probably going to kill me after this call, but she functions at this level every single day, because it's not, again, about her. It's about you, and it's about the people that she's trying to help, right? And making sure that there's always that humility there, but it allows us to make sure that people say, I can trust her. I can do that. I can actually be successful in asking for this help. And that leads us to the final issue, which is number 10, focus on data and not people, right? There are a lot of personalities in healthcare. We can all agree to that. There are a lot of conflicts that can occur with personalities, right? But your data has to be robust. It has to be transparent. It needs to be collected for a purpose. Please, please, please don't be the person that's collecting data just to collect data. Right? We need to have an intent, a data management plan, a data action plan in order to really do something robust with this, because it is part of our quality improvement approach. And only through data that's quality improvement driven are we going to actually reach our sort of service excellence. Again, people don't say, I'd like to have average patient care. They say, no, I'd like to have great patient care. Most people are just not going to say average because it's their life, it's their health care. So why would we want to focus on giving average care when our data supports that we can actually give great health care, but we also need to use that to justify things like FTEs and staff raises and more equipment and that type of stuff as well. And if we think about this in the concept of that Swiss cheese model, right, we're trying to prevent all those holes lining up and actually causing an issue. Right? Whether that's that preventable infection, whether it's that preventable fall out of the bed, whether it's that wrong site surgery that we have, or that bad medication error that should have never happened, right? There are ways for us to mitigate some of this risk. And a lot of that's going to be driven in that just culture system that allows us to look at the system, the performance, and the person. Right. And so IHI and Just Culture came up with this sort of 7 strategies for creating psychological safety. Right. And so I've included the web link there. This is a very timely one, especially with what happened in sort of Nashville. But it's really all about the concept of don't look at the person first, look at the system. Right. How do we focus on what our goal is, which is to reduce harm? Look and make sure your HR disciplinary policies are aligned. Look at a root cause analysis. Get your organizational leadership involved, right? And really also work with your regulators to say, how do we make sure that we're doing the absolute right things for our patients, but also for our people? If you make a mistake in healthcare and you're worried about not just losing your job, but going to jail, I think we can all certainly relate that we're not going to have a lot of people say, I'd like to sign up to go in healthcare. That is definitely something that is really a big challenge for us. And so from a recruitment standpoint, we have to be careful about what we ask for. And this algorithm really focuses on 3 basic areas: human error, at-risk behavior, and reckless conduct, right? Human error is what we do every day. The more that you do historically, the more errors you're going to make. That's how you learn. That's how you grow. right? At-risk behavior is sort of what I feel like when I ride in the car with Ruth, because sometimes she can speed a little bit, right? So it's that at-risk behavior where I know there's going to be a risk, but I don't think it's going to be significant, right? And then there's the reckless behavior where you just decide to do something completely stupid. One of the best examples I can think of is, you know that you're drunk and you get behind the wheel of a car, right? That is completely reckless conduct. Or maybe you come to work to the hospital and you're under the influence of something. Or maybe you're not in an emotional state to take care of a patient. Maybe you just had a loss of a loved one last night. You shouldn't be at work, right? And everybody would understand that. And so this is really that concept of, if it's human error, you console and you counsel and you try to improve that. If it's at-risk behavior, right, you coach that individual, because that now becomes a performance coaching issue that needs to be a little bit more formal. And if it's reckless, you either punish or what I call you expel, right? Sometimes you're going to punish and you're going to say, if you do this again, you're subject to termination. Or there may be something that's so reckless and so terrible that you actually terminate that person on the spot, right? And so that, again, is something where HR would work through this. And so this is actually the picture of the nurse from Nashville, just in case you're wondering who that is, right? And again, this is somebody who now has a criminal record as a result of a systems related issue. Now, does she have some ownership in it? Absolutely, for sure. But again, it's now set a precedent, right, that we can have criminal charges against someone who also makes a mistake. And so if we focus on what is our purpose, right, what are we trying to achieve? How do we get good mental clarity around that and maintain psychological safety? That's where we get into that sweet spot of patient safety, right? Because our patients want good care, but they also want us to be comfortable in advocating for safe care for our patients as well. And so that really sort of puts us back into this performance team model, where you got that common purpose, good communication, clear roles and responsibilities. You've got good engaged leadership. Your processes are highly effective and reliable, and it's built on solid relationships. That's where you get highly functional actual healthcare environments that are not only functional, but really profitable. There's a hospital that I know of here locally that does this extraordinarily well. And it's because their leaders sort of lead from the front, and they're very particular about this. So before we see if there's any questions, right, consider that all that we've been through over the last 2 to 3 years has certainly changed every single one of us in healthcare. And frankly, I think it's changed everybody. If it hasn't, you must have lived under a rock at some point, because continuity, right, of care is a huge thing that we have to focus on. It also reminds us that we have to focus on the most important things. I call it the rocks and the pebbles, right? If you got something small and it's a little tiny pebble and it's going to be okay and it's not going to cause any harm, don't focus on that today. Focus on the big rocks where patients and providers and team members and our healthcare systems are going to be harmed. That's something that we really got to focus on. And lastly is look around, right? Look at the people on your team. Are they all doing the very best that they can? And are you, as a leader, especially if you're in a leadership capacity, doing everything that you can in order to support their work and reaching their full excellence? Remember that most people don't leave jobs because of money. They usually leave jobs because of people, and it's usually the person that directly manages them. And so I always say, focus on the person right above your star players, that frontline supervisor, manager, director. That's the person that's really going to be the key influencer. If they love that person, they feel supported, that team's probably going to stay, or they're going to have a low turnover rate. But if they don't get along with that person, or they're not supported, we're going to continue to see some of these people leave. So with that, I'll stop and see if there's any questions or comments. And Ruth, I'll turn it back over to you and Dr. Ramirez. You're muted.
Hate when I do that. Sorry about that. I enjoyed the topic for a couple of reasons. Probably the main reason is that in infection prevention and control, a big area of emphasis right now is how do we lead change? We've seen so many of our failures, specifically during our COVID response, and this was in every healthcare setting. No place, I think, did COVID-19 response anywhere near adequately or safely. So when we think about implementing a number of these activities and responses to improving patient safety, what ideas do you have regarding how we should be looking at this with our own professional development? How do we take this and begin to think about, how am I going to start applying patient safety? How am I going to look at post-COVID care and systems and all of this. What might help me get started in making this a point of my practice emphasis?
I think, your point about just getting a level of awareness is absolutely the right place to start. Probably the best simple approach would be to start with something like the IHI Open School program. I just dropped a link in the chat box for everybody. So the Open School program is really focused on a couple core elements. It really looks specifically at patient safety, healthcare quality, leadership, and I think it has over like 30 CEs attached to it. And it's actually something that a lot of medical schools are now using as part of their programs when students want to graduate. And it gives you a very robust but manageable amount of modules to really get exposed to this. Once you have that awareness, your eyes and your lenses, if you will, start to change. Almost think about you're walking through your system, and now you have a microscope and you're able to see things differently. You're able to see, imagine if we could see the pathogens in the patient. You could say, I can see that that's Staph aureus and I need to give this antibiotic, and I never had to order a culture. That's what happens when you get awareness about patient safety. It's really hard for me to go anywhere now because I'm always thinking about this. I even think about this in hotels where I see a potential harm. I mean, this happened this past weekend, and I went and I said, there's a potential fall about to happen here because you've got a wet floor and you've got this and that. And I thought to myself, I am absolutely nerding out right now because I'm talking about patient safety in an elevator in a hotel in the mountains. But it can't escape you. And so awareness, sort of that training and education, but also partner up with your patient safety officers. There is a professional certification for patient safety. If you're an infection preventionist, I strongly urge you to take it. I think it is a excellent skill set. It is something that, would be great to have in addition to your, infection prevention certifications that you might have. And again, these are sort of overlapping sciences that have a lot to do with each other. That's why I got certified in healthcare quality and patient safety. I also got certified in patient experience because we need to have a more robust understanding of what the patient's expectations are of their experience so that we can actually deliver upon that. If you don't know your customer, you actually cannot be successful in achieving the success.
So for the infection preventionist who typically has focused on surveillance, looking at outcomes, we've got a whole new, a whole new arm of our profession. And I think, many may be already seeing information from APIC or SHE beginning to push forward that whole notion of change leadership. What does this mean? Because what we have done previously, performing surveillance, trying to come up with ideas for someone else to implement, but there is a unique strategy on helping someone coach others and guide others in creating change. So the IHI Institute, I think, is excellent. What do you think about, if I'm trying to look at environmental disinfection, what is the value of seeking out other professional associations? What should we be on the look for? How might we be able to pick out various resources, any kind of guides for how to approach some of our associations?
So thanks for that setup of a question, because in your ebook that Dave posted, I included the entire patient safety toolkit that has got about 15 different unique tools that you can use for any profession that you have. So for example, if you're an EVS director and you're looking to really do a quality improvement based project to operationalize a new cleaning method, for example, there's a toolkit in there for that. If you're a nurse that is looking to do something with your staff members, there's a toolkit in there for that. The IHI is probably one of the most professional agnostic groups out there that really has different modalities and methodologies that can be leveraged for any profession out there. And then you can always pull into your point, the professional association recommendations. What I have unfortunately found with professional associations is that they are very, very laser focused on their members and their interest only. And it's hard to look at sort of the broader field of patient safety or healthcare quality. That's one of the reasons that I have strategically said, okay, I want to get certain certifications so that I can look across the broader sphere of healthcare delivery. Because if you don't know healthcare quality, how can you do infection prevention? And if you don't know patient safety, you really can't do infection prevention. So infection preventionists do this already. It's just a matter of sort of formalizing that knowledge and saying, let's bring this to the table. It's also about increasing your literacy in certain areas so that as you have different discussions, especially across disciplines and even with physicians, you want to be armed with the right information. You know, healthcare quality experts have a very good way of being able to discuss data with physicians because they understand it. They understand that data really well. And you can't go talk to a physician like Dr. Ramirez, who knows data really well too, and not know your data. And so I think there's a fundamental professional respect that can be created when we up-level our knowledge and our skill set and go even outside of our traditional professions. But the professional associations can be good resources for that. But I would say go bigger and broader if you really want to affect change on a much more large scale.
Excellent. Thank you. Thank you. I don't see any questions in the chat. Dr. Ramirez, do you have any questions, comments?
No, I think that all the concepts that Hudson put together, they are critically important. Every 2 minutes you were giving us an important concept to remember. I understand that. Then you mentioned this, but I would like to ask you again. It's almost like everything depends on having a successful team.
Mm-hmm.
I mean, this team building that you look at this, you always come into. Then just to reemphasize, if I'm a healthcare worker and I'm having my team and I try to build my team, then what would be the primary concept for the person? You already mentioned this, but I would like for you to leave us with the basic elements that what do I need to do as a quote unquote leader to build up my team?
You know, the most simple way I could probably respond to that is to treat your team as if they're your own family. Now, for some people, that may not be a good thing, right? Because unfortunately, you know, not everybody's as nice as we all like to think we are. But I think in generalities, you understand what I'm getting at, right? Our teams, we spend so much of our time, especially that if you work 12-hour shifts, you spend a ton of time with your team. I can't think of the thousands of hours I spent with Ruth and Dave. You know, it's a ton of time. And I don't think I could have done that had I not liked them as not only professionals, but also as friends. And so, you know, if you take that approach as a servant leader and try to say, how do I help my people be their absolute best? And you give them everything you have, I'm a big believer that they will give everything they have to the patients. And so I think if you focus on that one core principle of servant leadership, treat your people as if you want to be treated, make them part of a team and let them feel a part of something bigger. People want to feel a purpose, especially right now. They want to feel a part of something special. That doesn't have to be a big paycheck. Yes, we all want more money, but we also want to be a part of something that's meaningful, impactful, and we want to see the tangible results. So share with them the data, the successes, but also be at the forefront of everything that we're trying to accomplish.
Excellent. Ruth, you want to close?
So that's a great way to close us out. I think that review about patient safety, initiating change, and how it's not all involved on an individual. You have to be working together to do that. So thank you, as always, for the information. And we look forward to seeing everyone next week. We've got a couple of topic ideas that we put in the chat. Dr. Ramirez and I will be working on that this week. But we will see you next Wednesday at the same time, same bat channel.